So welcome everyone. Welcome to those who are joining and those to come. This is the first event in a new imaging public awareness series. The title of today's event is "What is the role of imaging in a patient's breast cancer journey, early detection and improved treatment options and better outcomes?" I'm going to begin with a land acknowledgement. I'm going to acknowledge the fact that we are meeting on what is traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We know also that this is a virtual meeting and many of you may be on different territories, so please take the time to reflect on and honor the Indigenous communities of the territory where you are calling in from. Today, fortuitously, happens to be the anniversary of the world's first treatment of human cancer with cobalt-60, administered at the London Cancer Clinic in Ontario in October 27, 1951. I think that's a really great start to this particular public awareness series because it links so many aspects of what we're going to talk about. The higher energy emissions of radioactive cobalt-60 started an era of radiotherapy, leading that to more effective treatment of deep-seated tumors with less normal tissue damage. This treatment era continues today with linear accelerators using the same therapeutic strategy. So what a great way to start this series. So the goal of today's session is to highlight areas where research provides new avenues for earlier detection, better treatment with fewer side effects, and better overall outcomes for patients. After hearing the material in the presentation today, you may have questions about your diagnosis and treatment, and we would strongly encourage you to speak to your healthcare provider about any of the questions that relate to your personal treatment. So it's my pleasure to introduce the three presenters for today's event. Ms. Crystal Angers, a patient partner OICR, is also a senior medical physicist at the Ottawa Hospital Cancer Center, and she's going to be speaking about reflections on imaging in diagnosis and treatment. Dr. Martin Yaffe, senior scientist at Sunnybrook Research Institute, is going to be speaking on early detection and ways to avoid overtreatment with breast cancer imaging. And Dr. Muriel Brackstone, surgeon at London Health Sciences Centre, is going to speak on the impact of early detection on treatment strategies. So I'm going to begin by turning the floor over to you, Crystal, and welcome.
Let me know if there's any problems. Wonderful. Good evening, everyone, and welcome. And thank you for being here. And thank you to the organizers of this session for inviting me to talk to you this evening and to share my story and my perspective. I'd like to begin my presentation by telling you a little bit about myself and my breast cancer journey. I'll describe to you the numerous imaging modalities I experienced during my treatment, and I aim to do so from the patient perspective. I will conclude by reflecting on mammography and the challenges of early detection. So first, a little bit about me. My name is Crystal Plumager, and as you heard, I'm a medical physicist with 30 years of experience working in the field of radiation oncology physics. I've had the great privilege to work both in industry and in the clinic. Early in my career, while in industry, I worked as a medical physicist in various roles, including product management, project leadership, process engineering, and software development. And after 12 years of these industry roles, I changed gears and took a position at the Ottawa Hospital Cancer Center, where I certified as a clinical radiation oncology physicist. This was a significant move for me, and it took a year of study and the completion of some rather tough exams and a lot of hard work to accomplish. Outside of my medical physics profession, I have a full life. I have a loving husband, and together we have raised 3 remarkable young men. I have a large, close, and loving family, and many cherished friends that provided me with tremendous support during my illness. In my spare time, I enjoy skiing, I'm going on long walks, and I also love working with fiber of all kinds. I now consider that I have added a third perspective to my radiation oncology experience, and that is the patient perspective. In March 2020, coincident with the onset of the COVID pandemic in Ontario, I was diagnosed with stage 3 breast cancer. In the 6 months of treatment that followed, I endured 3.5 grueling months of chemotherapy, then surgery to remove the remaining tumor and the involved lymph nodes, 3 weeks of radiation therapy, and then hormone therapy, which will continue for the next 5 to 7 years. Shortly after finding the lump in my breast, and before my diagnosis was confirmed, I named my cancer Cecilia. It was good to use a name when cursing her ugliness and wishing her away, and it is easier to say Cecilia than cancer. Friends and family joined me in reciting inappropriate but effective mantras. One girlfriend even adapted the lyrics to Paul Simon's song so that we could sing of Cecilia's demise. The mammogram image that first revealed my disease will be forever etched in my memory. And here is that mammogram represented in fiber. Sinister Cecilia is this tangle at the bottom of the felted breast image here. She appeared suddenly, was alarmingly large, and was growing rapidly. At the time of diagnosis, disease had spread to my lymph nodes. I've considered these Cecilia's nasty offspring. In the background of this piece lies the coronavirus. COVID and its impact overshadowed my entire treatment experience. I went to all of my appointments, including my surgery, alone. While cancer and its treatment are awful, this piece of fiber art is meant to be cheerful. It uses all of my favorite colors and lots of glittery sequins and beads, and I crafted it to remind myself of the many positive aspects of my experience. In the slides that follow, I will aim to describe to you the various imaging modalities I experienced during my cancer journey. I have sorted them into the 3 legs of my journey: diagnosis, treatment, and ongoing surveillance. The extent of imaging involved in my breast cancer story is really quite remarkable and perhaps surprising. And it begins, as expected, with mammography. A simple X-ray of the breast. Mammograms are usually taken in 2 orientations: cranial caudal, which is shown here, and that's a view from the top down, or medial lateral oblique, or MLO, which are taken diagonally from the side. These are the ones I think we are most familiar with. Mammogram alone is insufficient to conclusively diagnose breast cancer. And so a biopsy followed by pathology is the only definite way to diagnose it. Ultrasound is used to determine if a breast lump is solid or cyst, solid tumor or cyst. And it is most helpful when evaluating death breasts, which can be difficult to read on mammogram. Also, ultrasound is also used during biopsy to help guide or find the area to be tested, as illustrated here. Next is MR, or MRI with contrast. That's magnetic resonance imaging. It's a very useful tool in identifying breast cancer and its spread. Contrast solution is injected into a vein in the arm and helps to create clearer images and identify abnormalities. I had an MRI at the onset of my chemotherapy and then again prior to surgery. I had a third follow-up MRI 1 year post diagnosis. Being terribly claustrophobic, I can tell you that these were necessary but traumatic experiences. Because my disease was high grade, that is to say it was fast growing, and because MRI and ultrasound had showed that the disease had already spread to my lymph nodes, there was concern about distant metastases, that is disease elsewhere in the body, such as the lungs or the bones. And to rule this out, 2 additional imaging procedures were required, a bone scan and a CT scan. For the bone scan, a radioactive tracer was injected intravenously. After a 2 to 4 hour wait, a large, slow-moving camera then scanned my entire body, searching for radiation emitted by this tracer. The tracer is designed to be preferentially taken up by fast-growing cancer cells in the bone, and therefore can be used to identify areas of concern. Similarly, a CT scan of my pelvis and chest were performed to look for distant disease in my lungs, liver, and bone. I'm very happy to tell you that in both cases, metastases was not detected. Imaging was also prevalent in the treatment leg of my journey. As I mentioned earlier, an MRI was performed prior to surgery to ensure that Cecilia had shrunk sufficiently to permit surgical removal. Then, just days prior to surgery, ultrasound was used to guide the placement of radioactive seeds into the lump in my breast. These seeds were an important aid in helping the surgeon locate the lump on day of surgery. On the day of surgery, a radioactive tracer was injected into my breast. Similar to the bone scan I described previously, a gamma camera was used to image and locate this radioactive tracer as it moved from the injection site to the nearby lymph nodes. The resulting image revealed the location of the sentinel nodes, or those lymph nodes that are most likely to contain disease. And my nuke med technician literally marked the spot with an X, a marker on my skin, and this formed another important aid for the surgeon. Once I recovered from surgery, radiation began. And the first step of radiation treatment was a CT scan referred to as a planning CT. This scan is used to develop a treatment plan in which a prescribed radiation dose is delivered to an identified target, while at the same time minimizing the dose to nearby structures, normal tissues. In order to execute this plan, it is crucial that the patient be positioned on the treatment couch exactly the same way they were positioned at the time of CT. To confirm this, linear accelerators, which deliver the radiation treatment, have onboard CT technology. A special CT called a cone beam CT may be acquired prior to treatment and compared to the planning CT to verify alignment. If necessary, the treating therapist will adjust the patient position so that it matches the plan. And so, prior to each of my 15 radiation treatments, I received a special cone beam CT. We've reached what I hope is the final leg of my journey, follow-up or surveillance. Here too, imaging is at the forefront with routine mammograms and ultrasound. Because I am now on hormone therapy, that puts me at risk for osteoporosis. So I will also enjoy routine bone mineral density scans, which utilize a dual X-ray scanner. But wait, there's more. I can also add echocardiogram, actually it's a transthoracic echocardiogram, that's quite a mouthful, and X-ray to the list of imaging modalities visited. The echocardiogram, which was really cool, was required to assess my heart function prior to the assault that is chemotherapy. A standard chest X-ray was also required during a very unfortunate early COVID visit to the emergency room to assess the cause of a chemo-induced fever. So, just in case you were not counting, my breast cancer journey to date has included 8 imaging modalities and 37 imaging procedures. This is a remarkable number, I think. In reflecting on the role of imaging during my breast cancer journey, I have the following thoughts. During diagnosis, imaging was essential in identifying my disease and assessing its extent. It played an important role in my surgery, providing the tools necessary for my surgeon to accurately locate and remove the disease that remained following chemotherapy. Imaging was a critical component of my radiation therapy and ensured the safe and accurate delivery of dose to the target while sparing surrounding normal tissue. So not only was imaging fundamental to my breast cancer journey, it was also prevalent throughout. However, I would be remiss if I ended my presentation here. I think it's important to share with you that mammography screening failed to detect my disease. With a strong family history of breast cancer, I was a candidate for biannual mammograms from the age of 50. However, a mammogram acquired in August 2019 failed to detect my disease. Just 6 months later, I presented with stage 3 disease. My tumor was 6 centimeters by 3 centimeters, and the cancer had spread to my lymph nodes. How does this happen? Well, mammography is not perfect, nor are screening programs. Mammograms can miss some cancers, and sometimes they can find things that turn out not to be cancer. The 3 photos here highlight just a few of the challenges. Cancer, both fast and slow growing, can be hidden or masked by normal structures. Can you all see the 2 lionesses in the picture? In particular, dense breast cancer tissue can make it harder to see breast cancers on mammogram. In the case of very slow growing disease, it can be very hard to differentiate cancer from normal tissue because the changes over time can be very subtle. On the other hand, a biannual screening frequency can be insufficient for the early detection of a fast-growing tumor. I believe in mammography, and I think it's the right tool for the job. I value highly the work done by our researchers and clinicians, and I urge them to continue to seek practical solutions that will improve early detection. I think about the wealth of information contained in our imaging databases and the new technologies such as artificial intelligence and machine learning that might help mine this data to better understand and differentiate normal structure from abnormal. I also think about the learning that may be achieved by close examination of breast cancer cases missed on screening mammography, and I encourage ongoing work in this area. Breast cancer survival rates have improved dramatically in the past 20 years, and I look forward to a future in which survival rates continue to improve due to early, accurate detection of disease. Thank you.
That's wonderful. Thank you very much, Crystal. If I'm not mistaken, are we holding questions to the end?
We are, Michelle. Yes, we are,
Great.
Michelle. Thank you.
So at this time, I'm going to turn the floor over to Dr. Martin Yaffe, who's going to present and speak to us about early detection and ways to avoid overtreatment with breast cancer imaging. Martin.
Well, good evening, everybody. Can you hear me okay?
Yep.
Good, great. So it's very hard to follow that because I think Crystal covered everything extremely well, but I'll see what I can add to the story. Let's begin. And I have to say, I can't see everything in my slides, so I apologize for that. I'm working with a very small monitor here. But first, I just thought I would like to remind you about the magnitude of the burden of breast cancer and how it kind of fits in with respect to our population, because frequently it's really not appreciated. So overall, the chances of a woman dying of breast cancer is about 3%. About 3% of deaths in Canadian women come from breast cancer. So that seems like a relatively small number, and that's because there's many other causes of death. But it turns out, despite that, breast cancer is the second largest cause of cancer death. And recently, it was the first for some time, but lung cancer has surpassed it fairly recently. For women under age 59, where there are there aren't that many competing causes of death, or at least they're not that likely, it's the largest cause of death, period. And of course, if a woman develops a breast cancer at a relatively early part of her life, typically on average, she might lose 20 years of that life. So the disease is important not just because of dying from it, but because of the total amount of an individual's life that they might lose if they happen to develop a breast cancer which is not successfully treated. So, oops, looks like I've missed a screen. I'd like to just mention that there are ways of detecting breast cancer earlier. They work, and there's quite good proof that they work. The idea is to basically detect the breast cancer by doing routine examination of women who are asymptomatic. And we'll distinguish between diagnostic imaging, which is when somebody has symptoms of disease, like breast cancer, and screening, where we're basically asking people who really have no evidence of disease to come routinely to be examined to determine if there are signs that are suspicious, and then could be followed up to determine if they have breast cancer or not. So screening for breast cancer has been shown for many years to contribute to reduction of mortality from that disease. And the proof for that comes from many different sources. The most important are randomized trials where women are given screening or not given screening, and one looks at the number of breast cancer deaths after a period of time between the two groups and compares. There's also what's called observational studies, and since screening has started, the screening programs that exist around the world have been carefully monitored to look at differences in breast cancer mortality between women who are screened and women who aren't. And a classic study was actually done in Canada and reported on in 2014, and was shown overall 40% fewer breast cancer deaths in women who actually received mammography screening compared to those who didn't. And the interesting thing is that benefit occurs over a broad range of age groups. You can see the numbers there. For women who began screening in their 40s, there were 44% fewer breast cancer deaths in the women who were screened. And as you go up, you see 40% for women in their 50s, 42% for women in their 60s, and 35% for women in their 70s. And as I pointed out, when somebody who develops breast cancer, especially relatively early in life, and dies from it, they may lose 20 years of life. The other benefit associated with early detection is that if the disease is treated earlier, and Dr. Braxton, I'm sure, will talk about this, one can reduce the morbidity. And by morbidity, I mean the adverse effects or bad, harsh effects that occur when you have to treat advanced disease. And of course, another consequence is that breast cancer and death and suffering from breast cancer doesn't just affect the individual involved, but also obviously their family, their friends, and somebody who's working. There's an economic effect both to their own family and in general, because that individual is absent from the workforce. So, as Crystal mentioned, it's very important to realize that breast cancer is not a perfect, that breast cancer screening, and particularly mammography, which is the most widely used technique for finding breast cancer earlier, is not a perfect test. its advantages include that in many cases it can be 80% or more or higher accurate in finding cancer if someone has cancer, and it could be 90% or more accurate if a woman doesn't have cancer and letting her know that in fact that's the case. So she can stop worrying about the cancer and know that she doesn't have the disease with reasonable confidence. Limitations though, as I mentioned, it's not perfect. Some cancers are missed. If there's 80% accuracy, it means there's 20% of cancers might be missed by mammography screening. And these cancers may be missed, as Crystal pointed out, because they're growing too quickly and the screening isn't being done frequently enough to capture them. Or even if it's being done reasonably frequently, they just may be very aggressive cancers that just tend to grow in between screens. And there's very little that one can do currently about that situation. The other thing is that about 10% of women who get screened will be called back to have some additional imaging procedure. Usually it's non-invasive, just to make sure that there's no cancer. This reassures the radiologist that cancer is not present. And of course, that does cause anxiety, which in most cases doesn't last very long. The benefit is that after the additional testing is done, the woman has greater assurance that cancer is not present. And some cancers, and again, Crystal mentioned this, and she showed a great illustration with the lionesses. Some cancers can't be seen on the mammogram, sometimes because the breast is very dense, which means there's a lot of fibrous tissue in the breast that can hide a cancer, and sometimes just because the particular cancer type causes it not to show up well on a mammogram. I mentioned some are aggressive and they'll grow quickly and large and become potentially lethal in between screening examinations. On the other hand, some of them are like the turtle in Crystal's example, where they grow so slowly that you probably didn't need to worry about them. You didn't need to actually catch them because they grow so slowly that they're not going to end up doing any harm. And these are the kind of cancers that are referred to as overdiagnosed. So they're cancers, if a cancer is growing that slowly, that it wouldn't be considered to do harm, treatment of that cancer can be considered to be overtreatment. And if the overtreatment involves something like chemotherapy or a lot of aggressive surgery, this would be considered as a harm. I also want to make a point of distinguishing between screening, which is intended to be done on women without symptoms, from diagnostic imaging, which is when symptoms exist. And there's a lot of controversy right now in terms of screening and how often it should be done or whether it should be done at all. There is no controversy whatsoever about the value of mammography in women who have symptoms. It's one of the tools in basically working up that information and proceeding toward treatment. Now, I wanted to mention the recommendations which are currently in place in Canada, and they come from the Canadian Task Force on Preventive Healthcare. This is a body that's been appointed by the Canadian government, and it's supposed to operate independently. In Canada, women in their 40s and those who are 75 or older are discouraged from mammography screening. The actual message is that they can make a decision about it, but the information that they're provided tends to discourage them from participating in screening, unless they're at particularly high risk because, for example, they might carry the breast cancer gene mutations BRCA1 or BRCA2. Women are also discouraged from practicing breast self-examination, which is more frequently called these days breast self-awareness. And there's no recommendations at all for women with dense breasts and anything that they should do differently, even though we know that women whose breasts are dense are at higher risk of developing breast cancer, and they're also at higher risk if there is a cancer present of having that cancer missed on the mammogram. And the task force also suggests that about half of all breast cancers are overdiagnosed. In other words, they didn't need to be found. And I don't have time to go through the details in this presentation, but that number is probably more like 10 to 15%. And most of those are what are called ductal carcinoma in situ. It's a different early form of cancer, and many of those are not going to be aggressive. Now, I believe this is very dangerous advice. This is the advice given by our task force in Canada. And the reason is that women in their 40s, 27% of the lives lost to breast cancer come from cancers that develop from women in their 40s. And again, 23% of the deaths from breast cancer occur in women whose cancers appear after they turn 75. So I don't think it's a good idea to ignore cancers in those women or discourage them from doing what they can to have those cancers detected early. And when we think about the self-examination, many women are not recommended for screening, and in some cases don't have access to screening. And in some cases, the only chance they'll have of having their cancer detected reasonably early is if they detect it by themselves, say in the shower. So why should we miss the chance of having that occur? I think it's an opportunity. It doesn't really cost anything. And it's an opportunity to allow women to have more agency in looking after their own breast health. When we go back to the issue of dense breasts, there are methods of imaging, and Crystal mentioned some of those, like MRI and ultrasound, that are more accurate in finding breast cancer in dense breasts. And I believe those should be available for women if they do have dense breasts. So I think better advice, and this is not the advice that's coming from the Canadian Task Force, is that women and their doctors, because their doctors are being given the same advice, the family doctors, should be presented with accurate information on both the benefits and the limitations or harm that come from screening or from not being screened. And then they can make their own informed decisions. I personally believe that women who are 40 and over, and those who are over 75 and over, but in otherwise good health, should be able to choose if they want to be screened for breast cancer or not. And furthermore, because we have such a shortage of family physicians in Canada, they should be able to self-refer for screening. And women with dense breasts, as I mentioned, should have access to methods for screening that are not impaired due to the presence of dense tissue. And these include breast ultrasound, breast tomosynthesis, and possibly in some cases, breast MRI. So how can we do better? How can we avoid missing cancers? Well, women should, I suggest that women attend breast screening and that they practice breast self-awareness. If they have over 25% lifetime risk of breast cancer, they should consider screening done with MRI, and that's available at least in the province of Ontario in a high-risk program. They should be informed based on their initial mammogram if their breasts are very dense, and then they'll know whether they should be thinking about the possibilities of supplemental imaging. And I'll mention that on the next slide. Now, the problem of being called back when you don't have breast cancer, the best way of avoiding that is to be screened at a facility where people are experienced and they do a lot of screening, and those places tend to have fewer callback rates or lower callback rates for women without cancer. But being called back should not be thought of as an error, but it should be thought of as the radiologist just wanting to be sure that a cancer is not present. And I think if people think of it that way, it will help to reduce anxiety. By the way, in the upper right corner here is an example of a breast MRI. And as Crystal mentioned, this is done using a contrast agent that's injected intravenously. And you can see here not only the 1 centimeter cancer, which is shown by that bright section with the upper arrow, but also a smaller cancer, which definitely would not have been seen on a mammogram, indicated by the arrow. So you not only get a better accuracy in finding cancer, but a better idea of how extensive the disease is. Now, how do you avoid overdiagnosis? Overdiagnosed cancers are cancers. They're not mistakes, they're real cancers, but they happen to grow more slowly and in some cases aren't very aggressive. They do tend to occur more, they're more likely to occur in older women, and the reason is that people die of other cancer, older people die of other causes before the cancer actually materializes to become a problem. That's cancers, the most frequently overdiagnosed cancers are DCIS or ductal carcinoma in situ. They're often harmless, but they're not always harmless, and that's why the radiologist wants to identify them. The problem is that we need better techniques in the pathology lab to predict which of these cancers are going to be aggressive and which aren't. And that's still a problem that we're trying to deal with in research. As well, radiologists are developing improved approaches to actually reduce overdetection of cancers, particularly DCIS, by trying to distinguish the patterns on the mammograms of the more and less aggressive DCIS. Crystal's already showed a great example of this, but I think the mammogram at the right, at least for those of you who are not familiar with the idea of breast density, this is a dense mammogram. The fibrous tissue in the breast makes it very white. Tumors show up as white, and seeing a snowball in a snowstorm is very difficult. So that's the problem of breast density in a nutshell. And I think Crystal's illustration was better, but it's similar to the Where's Waldo problem of there's so much going on in the picture, it's hard to find the important thing, which in this case is the cancer. So what we're trying to do, I'm getting towards the very end of the presentation, is to improve the approaches to screening to avoid missing cancers, and particularly to try to identify the women for whom the mammogram, as it was perhaps in Crystal's case, is not adequate to identify the cancer. And particularly that occurs in the case of dense breasts. And if we can identify those women, we can then recommend supplemental screening procedures for them. So this is what's called precision medicine. Use the tools that work best on the people who need them to improve detection of cancer, and also be more efficient with how we use expensive imaging resources like ultrasound and MRI. And I think the cartoon shows very well that one size, using the same approach for everybody for screening, certainly does not fit all. It doesn't work equally well for everybody. So this is just an example of a computer algorithm that we've developed in my lab, where we look through the breast on an initial mammogram. We identify how easy or hard it would be to find a cancer if there was a cancer in the breast. We come up with an index for the likelihood of missing the cancer, and we can therefore recommend which women might benefit from supplemental screening. So after their first mammogram, depending on what the masking score was, the woman could either continue in mammography screening or go to supplemental screening with another imaging technique. I'll just skip over this slide. We are doing a large study. Well, I won't skip over it because these are the people who are doing the work. Wonderful group of scientists, radiologists, physicians in many countries, in Italy, England, and in Ontario and in Rochester, New York, who are, including breast cancer survivors who are guiding us in our work to try to come up with a better way for doing precision medicine screening. In terms of overdiagnosis, there's a couple more things we can do, and I already alluded to them. We can look at what are called biomarkers that tell us how a cancer will behave, and use this information to try to identify the cancers that require, or the individuals who require more aggressive or less aggressive approach to what's found initially. So looking at the form of the cancer on the mammogram, there's a lot of new knowledge that's suggesting that the radiologists can, if they very carefully analyze patterns in ductal carcinoma in situ, they could determine which ones will be aggressive. This is just kind of hot off the press work, and I think in the next couple of years, these techniques will work their way into clinical use. And then finally, we can incorporate information from imaging like the mammogram or MRI, from the pathology lab once tissue is actually sampled from a suspicious area in the breast that's identified on the mammogram, looking at some of the biomarkers that are expressed in the breast, and in some cases using genomic information, combining that information to decide how aggressive the cancer will be, and therefore using the right medicine for the job, using a more aggressive approach for more aggressive cancers, and trying to be trying to reduce the amount of harshness of treatment for cancers that are not going to grow quickly. So there are advantages to earlier detection of breast cancer, reducing mortality, reducing the number of years of life lost, reducing the morbidity associated with treatment, and of course, reducing the cost to society of the deaths and suffering that are associated with breast cancer. Thank you very much.
Thank you, Martin. That's great. I always seem to learn something new from your talks, so I appreciate. Thank you. And at this time, I am going to turn it over to our third speaker, Dr. Muriel Brackstone, who's going to speak on the impact of early detection on treatment strategies. I see your slides, Muriel. That's great. And take it away.
Thank you. So from a clinician's perspective, we consider the progression of breast cancer as reflecting the activity of the cells. And so that's where we see the utility of the mammogram in really showing us where cells are overgrowing. And as the body deals with that, the dead cells get replaced with a fleck of calcium. And so when you see a lot of activity, all of a sudden you see these little flecks of calcium, and that can be an indication that there's overactivity from a benign perspective, from a pre-invasive perspective, or given enough time, potentially developing into invasive cancer. But one of the important things I want to highlight, once we've been talking a lot about mammography, is the difference, and Martin alluded to this, between screening and diagnostic. And it's fundamental to appreciate that you cannot rule out a cancer with a screening test. If you have a complaint or a concern, a screen is really to look at patients that have no complaints, no concerns, no lumps, nothing like that. Just a regular average person presents for a screening test. And the purpose of the screen is to highlight who should have more investigations, such as something that looks not normal. A diagnostic test is to definitively understand whether something that you have found or you're feeling is actually cancer. So it can include tests that are used as screening tests like a mammography, but must also include other tests like an ultrasound and further investigations. And so you cannot be dismissed by a physician when you had a mammogram only and it didn't show cancer. And I'll give you a good example here. This shows you some of the other progression beyond just the standard mammography that are developing over time, and other progression and newer modalities, such as 3D mammograms. So going from a 2D image to a 3D image allows the radiologist to scroll through and see with a greater eye some abnormalities, but you can really see on that 2D image, it'd be hard to pick out where the cancer is. And even on the 3D image, same. Where we're now moving at our institution is the addition of IV contrast. So the addition of a contrast mammogram, and then so you give an IV contrast and then you take a picture, can highlight quite effectively where there's an abnormality that's requiring more blood supply. And so the contrast mammography has been really useful for us in weeding out a lot of potentially false negative mammogram imaging. So that's how patients present. Either they had imaging and they were having screening, which prompted more investigations, or you presented with findings such as a lump, contour deformities, changes to the skin, nipple discharge, all of those things. So those are things for which investigations, including mammography, are required, but are not by themselves sufficient. And so things to worry about when there is a breast lump, and that's the only thing I would say, I think, made physicians give pause to articulating the need for monthly physical examinations was it prompted a lot of fear and a lot of investigations. So now that we understand better how we can navigate those, I think we can provide good information to patients when they are finding a lump that may be new or different. And so the important is to know the texture of your breast gland so that you can identify something that's new or different. If you present with a finding to your family physician and it's a little cyst and they aspirate it, but it doesn't go away or it comes back, or there's a finding in the mammogram that looks abnormal, or you have a lump, but the mammogram looks completely normal, but the lump feels hard and abnormal and it's new. If those things don't match, then you can't dismiss it. And similarly, you had a biopsy for something the radiologist was worried about, but the biopsy came back benign. Those things don't match, and so you can't dismiss it. So that's my important take-home message: not to rely only on a test, not to be easily dismissed if there's discordance between finding and a result. And if that's the case, then you should request and you should be referred for a specialist and voice your concerns if you have a worry about a spot. I wanted to articulate the difference that early detection can make in the form of surgical options. And so when the lump is small enough that you can leave a reasonable amount of breast tissue, the difference between lumpectomy and mastectomy is the same with regards to survival and long-term outcome. There are many randomized trials that have shown that with long 25+ year follow-up data. The survival is the same. There's a slight difference in local recurrence, but not one that amounts to a difference in survival. And so really, if you look at the difference in terms of the effect on your psychosexual sense of self, the scars, the deforming change that a mastectomy can have over a lumpectomy, we recommend lumpectomy in cases with early disease. Now, if the disease isn't detected early, we don't have that option necessarily. When it's really small and we can't even feel it and it's detected by imaging, we have to localize it. In other words, you can't feel anything. It's only, half a centimeter in size. And so I won't be able to feel it in the middle of the gland. And so we need something to help target the surgical excision. And so we've moved really to magnetic or radioactive seeds. There are many different types that are small enough that they can be introduced right into the lesion through a little needle. So by ultrasound or mammogram, freeze the skin, put a needle, slide this little seed, and it stays in place and it emits a signal. And then it becomes really easy. You go on with your detector, ding, 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 find the spot, cut it out, and then that's it. It provides a roadmap. So the radiologists implant these seeds. Other centers still use wires, which are a bit more historic, but they target the abnormality and then they draw sort of a map to make it easy for us. And when you're able to do that, you remove less of the normal tissue and you remove better the lump that you actually intended to take. And the reason that matters is because the more deforming the contour is, the less value the breast conservation has. So the purpose of breast conservation, if they have the same survival, is to make you feel whole, is to make you feel like yourself, like before, like you weren't mutilated by this surgical experience. And so we want to keep the breast as natural and as nice and as close to the other side as before your cancer. So there are many psychological benefits to breast conservation, but that's only if you can leave a reasonable amount. If you take a huge amount out, well, then there was no point because A, you can't fit a prosthesis on a big wrinkled conic contour. So not only can you not fit a prosthesis well, but you can't fit a bra well. So you're kind of in this in between, not having value from real breast conservation. And it might not seem like a big deal, but every little incremental amount that the cancer grows in size is exponential in the amount of volume that it occupies. And so that lump with a rim around to get clear of the margins, you can see of a diameter of 3 centimeters for a cancer, the tumor volume in 3 dimensions is going to be approximately 14 cubic centimeters, but the amount to take out with a rim of normal is going to be now 65 cubic centimeters. So it becomes a really big burden. So the smaller you can detect the cancer, the less amount you have to cut out of normal tissue. And while it seems like you could take a piece and just close the skin at first, your body fills it with fluid, but as it heals, it really sucks in the remainder of that tissue, and you can see it becomes quite contour deforming. And the same is true for outer quadrant. It tethers the nipple, and so moving the nipple position really to the eye for a naked patient is really altering physically, and then it's really difficult to feel a lower volume loss. And so these are examples of poor outcomes in patients who tolerated it and didn't say anything because they didn't feel entitled to have a good cosmetic result and should just feel grateful to have surgery. And now, thankfully, we've moved away from that sort of a paternalistic attitude towards surgical care, and we're providing patients with options that allow them to have a nice surgical result. And so it becomes not just lumpectomy or mastectomy. We have options if you have a large tumor to shrink it down to the lumpectomy manageable size with chemotherapy, or to use other techniques, which we call oncoplastic surgery. So that's a new, relatively new mode of surgical treatment where we use plastic surgery approaches to try to give a good result. And that's going to be what's left on the patient as their permanent reminder of their treatment. And so we really want to do a better job now. And an example of that would be these kind of small cancers. We lift the skin up now. And when you have seeds, when they're really small, you're not stuck taking big chunks. So you can take small pieces and you bring the gland together. So I make it akin to taking a piece of pie. You want to steal a piece of pie, but you don't want anyone to know that you stole a piece of pie. So you take your pie and you shimmy your other pie pieces so you have a smaller but rounded piece of whole pie. So that's what we're doing. We take this piece and then we cinch up the skin envelope, and then we end up with a really nice, pretty balanced cosmetic result. You can take, now if you have bigger chunks, you can take advantage of some of the additional droop or contour that women have over time. You get a little extra on the lateral part of the breast. You get a bit of droop, well, you can take that and cinch it around, take a piece of skin, and then you can end up with a rounder, big breast. I'm just giving you examples here, people that chose to have only one side treated initially, but you can get quite a nice rounded result. And similarly, you can use breast reductions for women that have larger breasts and take huge amounts. So when you have a big breast reduction, you can take 40, 60% of the breast off. And you can do that, but the piece you're taking off is the cancer piece. And everything that was droopy, because God knows that happens over time, you just cinch it up and you tighten up the envelope, and then you end up with a lifted but rounded breast result. And this patient, for example, you can see the dotted line in the outer aspect of her right breast on the left screen. There is a significant amount. You could never have taken that out and left a nice shape, but that was probably a third of her breast volume removed. And she has a smaller but lifted breast, which you can always augment later and match the other side, of course, which OHIP in Ontario covers as a covered service. The other important impact of early detection is the assessment of the lymph nodes. And so we standardly, before the early 2000s, took all the lymph nodes out of the armpit, which gave 20 to 30% of people permanent arm swelling, which might wax and wane, but it never went away. And a proportion of those people also had chronic pain. And that can be really disabling. Your hand function stays, but your arm is so swollen that it's heavy. It's hard to use your hand. You get recurrent cellulitis. It becomes really problematic. And so we realized that we're doing that for people who didn't even have disease in their lymph nodes. And so we moved to the lymph node sampling. And then only now recently are we able to expand that to people who have even a little bit of lymph node cancer without having to take them all and giving them lymphedema. But the earlier and the less involved the lymph nodes are, the more you can use this procedure and just sample the lymph nodes. Just take the first couple instead of taking them all, and they don't get lymphedema generally that way. If you take all the lymph nodes out, there are also a number of important nerves going through the armpit, which can give people not only just numbness, which is uncomfortable in the armpit, but also some winging of the scapula when you push on your arm, or potentially chronic pain, which can be really quite disabling. Here's a picture of the lymphedema arm that we were speaking of. With regards to chemotherapy, one of the greatest advances I would say in most recent years has been the recognition that cells are very different, and you can use these tests, which are tests for the genetic signatures of the tumor cells. So this tumor that's removed, you send some slides to a company that has patented a gene signature. They extract the cell's DNA out, and they look to see, are these types of cells capable of a recurrence? Because if they aren't, you don't need to add chemotherapy. You're over-treating them. We over-treated a lot of women with chemotherapy and gave them permanent numbness in their hands and feet, all sorts of issues, heart disease, and all sorts of effects from chemotherapy unnecessarily. But you didn't know who you needed to treat, so we wanted to safely treat everyone. But now with early stage disease, if you don't have a high risk, there's clear evidence that you don't need chemotherapy. So particularly patients who are lymph node negative. With regards to radiation, it's a standard treatment for patients if you're keeping the breast tissue, so you remove just the lump, or if you have a lymph node positive disease. So even say you didn't want to do radiation, so you decided you wanted to have a mastectomy with or without breast reconstruction, which you could do immediately, but your lymph node already had cancer in it, you're still going to need radiation. So you can avoid some of those additional treatments, which might not be that consequential, but radiation causes quite a bit of fibrosis. And so if you're wanting a mastectomy or looking at breast reconstruction, there are significant complications related to radiation, even though it's effective, that you have to suffer through the fibrosis, the burning of the skin, the tethering, and the pain from contour tightening around an implant reconstruction. And so being able to avoid that or having the option to avoid that because of early disease is pretty significant. I'm particularly interested in pre-op radiation because with early stage disease with a tumor in place, it really gives you an opportunity to try different types of treatments. So I had done a study looking at giving patients before surgery a single dose of radiation right to the tumor based on this early study just from the 70s, looking at patients who didn't get any other kind of treatments. They all had mastectomy, nothing else. They were randomized to radiation before surgery, radiation after surgery, or no radiation at all. And the patients who had radiation before surgery actually had a survival benefit. So I think that there's an immune piece that the radiation can prime, and maybe that's going to be a helpful piece in the future, looking at where we can move. And so this was a study that I had done looking at image guided, so it was MRI guided radiation before surgery. And the problem we had to overcome is everyone gets radiation when they're lying supine, so lying on their back. But your MRI that we wanted to guide it is with you lying on your stomach. And so I used this as an opportunity to bring to our center radiation delivered lying on your stomach, which I think has a great opportunity when the lesions are small, where we could target the breast by radiating below the chest and not radiating through the chest, particularly on the left side where we'd suffer some of the effects of radiation through the lung and the heart potentially. And these are the patients pre-op, post-op, and at 6 months. And you can see, even though they had full dose of radiation, so they had 21 gray delivered in a single dose, so in 12 minutes instead of at the time 25 fractions over 5 weeks, they had excellent cosmetic results. And the other thing it showed us is that it actually does prime the immune system. So there's more work that we're doing now in different studies looking at which amount of dosage we can actually use that primes the immune system to actually recognize the cell. And you only can do that with the tumor still in place, with hopefully some capacity to recognize and ignite the immune system to know those cells so that if it ever tries to come back again, it can kill it. And so I would say the future of breast cancer is early detection of disease to allow for lesser treatments, impacts on radiation, chemotherapy, and surgery. And maybe we could understand cancer perhaps as more of a weakening of the immune system that allows these abnormal cells to be tolerated instead of really thinking of it as a problem of that cell gone awry. The problem is that somebody allowed that cell to still continue to live after it had gone awry. And if we can prime the immune system to recognize and not tolerate that, then we can create, in essence, an in situ vaccine against the recurrence. But that's not going to be really effective or in the same way feasible if the cancer is already spread. So if we're not detecting cancers till they're already in the lymph nodes, so they're already sizable, then you're playing catch up as opposed to preventing something from being allowed to transmit. So in summary, what to expect if your biopsy shows an abnormality. The surgery will either remove the lump, which is our standard, and or lymph node sampling. The earlier the diagnosis, the smaller amount of tissue we can excise, the better the cosmetic look, the greater the options we have to create a really good cosmetic result. We would expect most patients are going to need some staging tests to make sure there's no spread anywhere else. And if there is high risk tumor types, so if they have features that are fast growing, they don't eat estrogen for food, so we can't use the hormone tablets, we need to use chemotherapy to reduce the risk of recurrence, particularly if they have a high recurrence score. That may include IV Herceptin, which is an antibody-based drug that you take every 3 weeks IV for a year. So it really does drag out a significant impact of treatment, particularly in patients whose disease is larger or spread to the lymph nodes. That could potentially be avoided with early stage. Similarly with radiation, hormone tablets are obviously a common adjuvant to reduce recurrence, and then mammograms for follow-up annually. So women need to and should advocate, listen to your bodies, and bring a concern to a physician. And if that's not enough of a resolution, then seek a second opinion, or don't be afraid to ask for a specialty appointment to bring that to resolution. I think that that's important. Thank you.